Thanks, Liz. That was great. Lots of information there. And I think really important to acknowledge the carers, because we do put a lot of onus on the carers, you know, and we forget that sometimes this ends up, have we lost the lights? Yeah, and just a lot of burden for carers that we see, and a lot of burnout. Our final speaker of the morning session again is Associate Professor Michael Back, who's a radiation oncologist here at Royal North Shore Hospital. He's going to talk to us today about the timing and risks of repeat radiation therapy, which I think leads on very well from Liz's avastin talk. Thank you.
Great, thank you again for the opportunity to speak. Yeah, this is a new concept, or relatively new concept, which is coming back into the potential treatment regimen that people can be offered at time of relapse of their tumours, be it glioma, be it brain metastases, be it meningiomas. So a little bit of a primer on radiotherapy, just to update people and people who may not have had that experience. Radiotherapy is targeted and precise. It's individualized to the target area of the brain. It aims to damage tumour cells, but the normal cells can repair that damage, and so you get a difference between tumour cell kill and the normal cells surviving. The radiotherapy in 2023 is extremely targeted, and we use a lot of information from MRIs and PET scans to really focus in on where the tumour is and try to identify where the tumour is, and also where the tumour might be infiltrating in the brain, so to try and get that next site where the tumour might be progressing. And we can do this with improvements in digital technology and software, and allows us to treat more of the tumour area but spare a lot of the normal brain from receiving high doses of radiotherapy. It's given on a machine like this, and the machines are fairly standard around New South Wales and Australia. All the MRI, so all the linear accelerators, the treatment machines, now have a built-in CT scanner where you're allowed to image the patient before the start of treatment to make sure you're in the right position. And that allows everything to be very focused and accurate. Most of the side effects from radiotherapy, apart from lethargy, hair loss, but the significant ones come down to the site in the brain, so which part of the brain you're treating, and generally comes down to swelling. That is the biggest issue we face. And I talk to my patients about saying, hopefully you're going to be a shrinker rather than a sweller. If you're a sweller, we need to manage that. The journey can be a little bit more uncomfortable. When we talk about the risks of swelling with that initial radiotherapy, where we're treating the tumour in the adjacent brain, the risk of early significant swelling is around 20%. Now, it's not the brain that swells, it's actually the residual tumour, the surgical cavity that swells and then causes effects on the surrounding brain. In dosing radiotherapy, historically, and the total dose we give is really the same dose as we gave in 1980, and that is, it accepts a risk of less than 5% of bad late swelling or a stroke event. And that bad late swelling is a condition we call necrosis. So that's the significant risks that people may face. Now, what is re-irradiation or repeat radiotherapy? So this is a very simplistic view. Here's the initial tumour, initial treatment site, then there's a relapse, so we then repeat the radiotherapy again over that area, and so you get an area that's overlapping in that normal brain, or around the tumour, but also in the adjacent normal brain. Now, that historical dose of radiotherapy we gave here was around 60 units of radiotherapy. Here, when we're repeating the radiotherapy, we're giving somewhere between 35, 40 units of radiotherapy, a bit quicker, so over 2 weeks or 3 weeks. And so in this area here, you're getting doses of radiotherapy which are up near 100 units. So you're getting very, very high units. And the brain remembers the previous radiation dose, even if it was given 15 or 20 years previously. So you're getting an overlap of that same area of the brain, and therefore you're exposing that area of the brain to getting impact. So here's some examples of overlap. So when we're re-irradiating, it's where we're overlapping. So here's the initial area, then the secondary area. So that area there is the area of overlap, of getting more than sort of 85, 100 units of radiotherapy. And this is two different examples of that. So the risks of when you're doing that is that you cause this condition called necrosis. Remember that when we initially designed the radiotherapy, we accepted a bad risk of that sort of event of around less than 5%. But when you give the radiotherapy again, even if it's 12 months, 18 months, 10 years after the event, those risks go up really high. And they go up to bad necrosis is around 30%. One of the US studies had 50% of the patients requiring a repeat surgery within 2 or 3 months after radiotherapy. And that's not good. So as a result, and that's all this sort of inflammatory process that we spoke about before, that meant that re-irradiation historically was not feasible without negative impact on patients' quality of life. So I've been managing patients since, as a specialist since 1996, and my first true re-irradiation was around 2010. You just didn't do it because you end up with these catastrophic side effects. But then along came avastin. So avastin, as Liz has outlined, bevacizumab, is a drug which came around, first study reporting here about 2007, and showing the benefit in recurrent tumours to temporarily improve symptoms and survival duration in recurrent glioma. And this is some of the results we see with avastin. This is a recurrent tumour here, and then 4 weeks later, that's the area there. So avastin helped to slow down the progression of the tumour when the tumour had relapsed and improve some of the symptoms that it was causing by reducing the mass effect. It often made the scan look better, but unfortunately it was only a temporary benefit in a lot of patients, and the tumour then progressed after the avastin wore off. But at the same time, we saw that effect in avastin, and some studies came from overseas showing that avastin actually helped reduce or heal radiation necrosis in people who have been treated previously for other conditions. And the results were dramatic. So this is a randomized trial, and the response rate in the avastin arm was 100%. Response rate in the placebo arm was 0%. So the study was closed after about 16 patients. And then they crossed over, and the ones who got the placebo up front then responded in 80-odd%. So it was a very effective drug to show that the avastin could actually heal the radiation necrosis. And this is an example of a scan of a patient with radiation necrosis. The first person in Australia to receive avastin for radiation necrosis back in 2011. And these scans are only, from there to there is only 6 weeks apart after avastin, and then this is the same image at 2 months later. So that whole inflammatory change settled down. So avastin was seen to be an effective treatment for radiation necrosis of the brain, and the avastin or the bevacizumab may heal the brain swelling side effects of re-irradiation potentially. So we looked at that in our own patients, and we reported on this, and we showed that the avastin could protect that swelling that could occur, that we'd expect to occur after re-irradiation. And then we published our own data on patients who have been re-irradiated and showed that was a feasible option with potential benefits in patients that we weren't experiencing previously as another treatment option later on in the course of therapy. And then last year we had a randomized trial come out, reported in end of last year, which showed that re-irradiation when added to avastin showed it could further delay relapse and recurrent glioma and improve that time to progression. So in 2023, we now see re-irradiation as being a viable option for our patients. So what are the issues? And this is intentionally, there's no data to associate with all these questions because unfortunately we don't have the good definition of data. We've only got anecdotal evidence. So I've now probably re-irradiated over 150 people compared to 2010 where I hadn't re-radiated anyone, and we've now learned the lessons over that period of time. So first question, it's a series of questions. When is the best time to offer re-radiation after relapse? Historically, because of the concerns over side effects, we've left the re-radiation as a treatment option when chemotherapy has stopped working, and also when avastin has also stopped working. So we bring re-radiation in many ways off the bench as a later option for treatment. And most of our data shows that that is still an effective option at that point of time. But around the world, we're now seeing a movement to giving re-radiation early. But there's real important selection criteria in patients. So to try and pick which patients are appropriate for re-radiation depends on different periods of time. If there's no overlap, as demonstrated in one of the previous slides that Liz showed, then you can give a repeat high dose of re-radiation fairly safely. But if there's a lot of overlap, then you're concerned that if the patient responds well, there might be issues happening 12 months or so down the track. And this is important for our patients with IDH mutated tumours and the favourable natural history type tumours where those side effects might occur in people. So we generally leave that till a bit later, especially if there's a lot of overlap. Also, we've got to look, is a tumour just advancing on one front or is it advancing on multiple fronts in the brain? Because the more fronts it's going through, the more likely you're going to potentially exposing risks of side effects. And as you get further on, it's not just the swelling, it's the little areas of stroke or perhaps damage to the nerves that might occur in our group of patients. So trying to pick which patients has to be very much individualised. The best way to deliver the re-radiation, you don't want to go through another 6-week course of treatment if you have progressive disease. So we truncate the course, but by also doing that, we're giving a higher dose each day to try and trick the tumour. And if we've got avastin on board, then the potential side effects by giving a higher dose each day can be modified. So often the courses of treatment, if it's a significant lump of tumour, might be 3 weeks rather than 6 weeks. If it's a smaller lump, you might look about giving 2 weeks. If it's just a very limited lesion, it looks a fairly isolated lesion, then sometimes we use that in just one dose of radiation, what we call stereotactic radiosurgery. But most of the time in the patients we're treating, they're large tumours relapsing back in the area that we've previously given radiotherapy before or in the adjacent tissues. We'll accept a large overlap and we give that course of treatment over about 3 weeks. Should avastin be used in all patients? That's controversial. So in many of our patients, they've been on avastin and I'm treating them once they're progressing on avastin. But if we're treating someone up front, sometimes you don't want to give people avastin because there is, as Liz outlined, there's inherent risks with the avastin even though they're low compared to the risks of the disease. But in watching patients where I haven't given avastin up front, you generally start to run into problems with swelling by about 6 weeks after treatment. And those swelling issues might impact on quality of life. So if I'm treating a large area where I think where I can calculate there's a lot of overlap, then I generally will say, let's give the avastin up front, give 2 doses of avastin, and then we can come in with a re-irradiation at that time. What are the usual side effects of re-irradiation? It's actually tolerated well in the initial course of treatment, especially if the avastin's on board, because it's working like really good steroids or dexamethasone to suppress any of that sort of symptoms. And you can avoid dexamethasone in the majority of cases. However, sometimes we do need a little bit of steroid just towards the end when people are getting tired, or it could be just a little bit of swelling that the avastin needs a bit of help with. How should the tumour be monitored after the re-irradiation? It's really difficult because once you've had re-irradiation, especially if you have avastin on board, it's hard to judge. There are various MRI sequences we use to try to get a clue of what's happening elsewhere in the brain, but within the area where there's a big area of overlap of both doses of radiotherapy, those areas are hard to assess and measure. And for that reason, sometimes in the clinical trials that are coming through, there's an exclusion criteria of patients who've had re-irradiation. And that's another aspect when we're discussing re-irradiation with patients, that if there's a clinical trial around the corner that we might be wanting to get a patient access to, then we probably should hold off on that re-irradiation until the access to that clinical trial has been sought or confirmed or declined. So in summary, the re-irradiation in 2023 compared to, say, 2010 is now very much a feasible option and is becoming part of almost our routine care as patients progress on during treatments. Using the avastin with that re-irradiation does provide additional benefit, not only with the avastin helping with the tumour, but also it helps to reduce down the side effects of the re-irradiation. I like to say that the two work fairly synergistically. Avastin needs something else to control the tumour after a couple of months because the avastin wears off. So avastin needs a friend and the radiotherapy needs a friend, and the two work close together. The timing of re-irradiation remains really uncertain, and we need more work and more research to work that out. But there is a trend to using the re-irradiation earlier in our practices, especially if the systemic options are limited or patients aren't tolerating the chemotherapy due to blood count matters, etc. Once again, this is all governed through our neuro-oncology MDT, and especially when we're starting to map out recurrent tumours and looking at where the tumour is going, we need the help of our neuroradiologists, such as Jamie Drummond, and our PET scan people who help us to design these treatments. And as Liz outlined in her great speech, there was a lot of support that needs to go on for all of our patients, and the whole team provides the support to the patients and the carers as well. And that's an integral part of allowing patients to accept treatments that we might be able to offer. Thank you.